All right, good afternoon. I'm Dr. Lee. I'm the moderator for this afternoon session, and it's my privilege to introduce Dr. Mark Gordon. Dr. Mark Gordon is an international speaker and author and a thought leader in age management. We first met at this meeting, not at this hotel, but several. There's a lot of different hotels that AMMG goes to, but when I first met him, it was really impressive, and we became good friends. And since we've been working together, I've been so impressed that he has this passion in neuroendocrinology. I mean, he's board certified in family medicine, but he knows more neuroendocrinology than most endocrinologists. So I'm really impressed. And I really think that he's a dynamic and also exceptional speaker, and this lecture I think is going to really excite you. So let's give a nice warm welcome to Dr. Mark Gordon.
Thanks. Only believe half of what he said. The good half. Anyway, the thingamajig's over here. This lecture on secretagogues is to address a couple of very important aspects to our practice of age management. Interventional endocrinology is the term that I use, because as the cost for growth hormone continues to go up and up, and the hurdles and the barriers for our use of it by the federal government and also by the state medical boards. I sit on the California Medical Board, and I see cases that come by where physicians are appropriately using growth hormone but forgot to do a challenge test, which is a big no-no. So the federal government, because they've got so much money, federal government has passed the policing of the use of not only testosterone but also growth hormone back to the medical board, and they're the ones who are going out on the witch hunt. Anyway, this discussion is on secretagogues. I try to be non-prejudiced as can be, since there are a number of good products out there. And in my practice, I used to use some 40,000 units of growth hormone a year because of these changes in the legal milieu. I didn't want to lose my license, go to jail, and have my 3 daughters think I'm a loser. So looked at the world of secretagogue technology back in 2001, started working in that venue. And secretagogues should take the position as, now, with the information I'll give you, should take a position as the logical first step before you go into using injectable growth hormone. Because the literature does support the efficacy of the products. It's not 100%, as you'll find out in the Sunday lecture on traumatic brain injury and hormone deficiency, that if the pituitary is involved in 14% of the cases as it's documented, you can't get a secretagogue to work. And in those cases, you absolutely need to put injectable growth hormone into the mix. So regulations, as I said, are very stringent these days, and the medical boards and DEA will be on you. Now, even though growth hormone is a RX, it's being monitored like a class 3 drug like testosterone. And as you probably already know, HCG, which was an RX, is being monitored as a class 3 drug in 16 states. I also have a pharmacist license and have to keep up on other states and what's going on. So in order to be able to do or dispense or prescribe growth hormone injectable, you have to perform either an ITT, which is contraindicated in anyone with cardiovascular disease, heart attack, or someone who's had a traumatic brain injury, because it can induce in everyone but Dr. Lee's patients, hypoglycemia. The GST, which is the glucagon challenge test, which is another that is used. Insurance companies prefer the ITT, but you can still use the GST and have protection against one of the agencies coming in and harassing you for failing to do a study. It's not mandatory, but it's recommended. And if you don't want to have them, splitting hairs that you didn't comply with the standard of care, make sure you do a challenge test. Cost considerations, somatotropin cells for $24 to $42 per unit, about $1,000 a month. It used to cost about $280 when we used to get the compounded growth hormone legally brought into the United States in New York. and then disseminated until the government came in and said, you're spending $1.2 billion sending it to China for 190 amino acid chain of growth hormone. We want you to stop. Otherwise, when this company, they said they'd take them into court and have them burn a couple of $1 million. And they'll probably win, but they'll still lose the ability to circulate growth hormone. So efficacy, the secretagogues are being found to be very efficacious. As I said, there's an anatomical failure of function in 14%. Some of the products that I look at, there's a 11% failure in some of the other products. And just to touch base that we're talking about the same thing, a secretagogue is any substance that causes another product to be secreted. So similar to what growth hormone releasing hormone does, it stimulates the somatotropes to produce growth hormone. So all the growth hormone secretagogues take that position of trying to stimulate the brain to produce and release growth hormone. Well, it turns out there's about 7 different pathways. Unbelievable. You know, when you look at the pathways that are available, you know that whoever designed our system wanted to make absolutely sure that there was an adequate amount of growth hormone pumping in our body every second, every minute, every year of our life, because of the functions that it is involved in, or the functions that they're involved in, or it's involved in, is so overwhelming. That's another story. Anyway, many of the secretagogues used presently are single pathway products. As I just said, the most common ones are the ones that stimulate or simulate like growth hormone releasing hormone and stimulate the receptors to release somatostatin or growth hormone. Newer products are being developed that address one or multiple of the pathways, the 7 different pathways. The issues that have to be looked at with a single pathway is tachyphylaxis, just like with any other product, and something called homologous downregulation, where I'll show you an article where it talks about prolonged or repetitive stimulation of somatotropes leads to their downregulation, or stimulation of the receptors leads to downregulation. The body is trying to make sure that the production of growth hormone is very tightly controlled. Some of the players in the process of our production of growth hormone, the anatomical structures, the hypothalamus, the arcuate nucleus, paraventricular, and the pituitary, and then the chemistry that's involved from ghrelin, growth hormone receptor, somatotropes, somatostatin, growth hormone. There are 5 different variants of growth hormone that our body actually produces. We only talk about one. The importance of having a healthy liver. Growth hormone goes to the liver and stimulates your IGF-1, your IGF-2, your binding protein 1 through 6, and something called acid labile subunit. How many people test for acid labile subunit, ALS? No one. Okay. It's a good start. Also, IGF-1 and IGF-2. IGF-2 is the main growth factor that's in the brain as we're developing. Very, very important. You can stimulate it to be produced, so people with traumatic brain injury, post-stroke, and so forth can have the benefit of recovery repair to some degree. Dopamine is a receptor, DR2 receptor, stimulates growth hormone. Then there are some of the coupling proteins that deal with interaction with the growth hormone releasing hormones. Vitamin D, believe it or not, has a major function in the brain, and that's why if you read some of the literature, the benefits with depression, dementia, and Alzheimer's from growth hormone level. And then melatonin. Melatonin in and of itself is an incredible antioxidant, protective antioxidant, as well as it itself stimulates growth hormone production. So central and peripheral control of growth hormone. Centrally, you know, you've got the growth hormone releasing hormone that stimulates or connects with its receptor, stimulates somatotropes to produce growth hormone. If your growth hormone level gets too high, then somatostatin, also referred to as somatotrope release inhibiting factor. The liver is circled down below because if you have someone with fatty degeneration or on certain medications, you can lose the maximum benefit of growth hormone stimulating IGF-1. And we've spoken about IGF-1 as being the moderator or mediator of GH. Well, it has a lot of things that IGF-1 does in and of itself, as well as growth hormone has a long list of things that it does itself, so you need both of them. But in terms of enhancement of ribosomal protein synthesis, IGF-1 does it. In terms of cortical bone, growth hormone does it. In terms of insulin crossover, IGF-1. In terms of breaking up body fat is the growth hormone. And then peripherally, as I said, liver, IGF-1, 2, binding protein 1 through 6. Binding protein 1, if it's deficient, there's a higher occurrence of ischemic heart disease. In the 4s and 5s with diabetes and orthopedic bone failure, bone growth, and 3, believe it or not, IGF binding protein 3, which we seem to talk only about, is responsible as a major anti-cancer product, which is in another lecture, but it's extremely important. So when you do your standard testing, make sure you don't fail to include binding protein 3, because you need to raise it. Quercetin can raise it. Pituitary. Okay, so liver helps to convert the growth hormone, growth hormone stimulates the liver to make these other products, these secondary wave products, which feed back to the pituitary and regulate its own production. In the brain, growth hormone can downregulate its own receptors. So just a little bit of that anatomy that we all loved in neurology. Paraventricular nucleus is where somatostatin is produced. The arcuate nucleus is where the growth hormone releasing hormone is produced. And then we have the supraoptic nucleus where we have a lot of products being produced. And then down below you have the stimulation. I always find so much fun in playing with in PowerPoint, you know, trying to do things that I wasn't able to do yesterday. I did that last night at 3 in the morning. So it's cool, huh? Anyway. It's what it is. Anyway, healthy aging cannot be achieved with a growth hormone deficit. It is involved in every cell of the body, from the 40-60 subunit of the ribosome to chondrocytes to stem cell stimulation. And about 40 years of age is when I just couldn't get it to be confluent. It blips off. So if anybody knows how I can fix that, talk to me after the lecture. I'd appreciate it. The drop below this 250, there was a question earlier with Dr. Rouzier asking about what the ideal level of growth hormone is. It was a paper published by Eric Braverman who looked at 350 and less and looked at the medical conditions of a large population. I think it was published in Endocrinology. It was published in one of the major journals. And he saw this correlation between less than 350 in growth hormone measurement and occurrence of multiple medical conditions. I leave mine about 275 to 300. So it's important also to understand that when you do measure your growth hormone levels, that timing is very important. And what you test is very important because the half-life of growth hormone is 20 minutes. And what's the time frame that we're producing growth hormone? It's from 8 o'clock at night till 4 in the morning, and you get those peaks. So at 9 o'clock in the morning when you draw blood, what are you really looking at? Are you looking at the peak? You're looking at the very trough of troughs. And then when you look at the IGF-1, it has an 8 to 10 minute half-life. But if you look at IGF binding protein 3, which has a 20 to 24 hour half-life, which is responsible for carrying the majority of our IGF-1, you get a more linear relationship between growth hormone production. What I mean is that there's a linear relationship between growth hormone that was produced and the ascent of binding protein 3. So you know if you have a low level of binding protein 3 at 2,000, 3,000, you're not producing very much growth hormone. If you have a level of, forget IGF-1 for the second, if you have a high level, like I just had some labs sent to me, the gentleman had a 5,600, 5.6 on your scales, 5,600 on ours, and his IGF-1 was 136. Well, if you just did IGF-1, you'd say it was low. But if you understood the relationship between the IGF binding protein 3 and IGF-1, you would see that he is making a significant amount. Otherwise, you have to do a 24-hour urine and then see your growth hormone level. ALS is a protein carrier that forms what they call a tertiary structure. You've got IGF-1 and then binding protein 3. That lasts for 20 to 24 hours. And then what sits on top of that is this thing called ALS, acid labile subunit, which extends the half-life for 200 hours plus. So you've got this three-tiered system: immediate accessibility to growth hormone, a delay, and then an extended delay. As I said, for some reason, we have all these pathways and all these systems to maintain a great level of growth hormone for a reason. So, stimulation of growth hormone secretion, all these things can assist in the stimulation of, no pointer, what's the one? Okay, so sleep, increasing your melatonin, making sure that there's no light to interrupt your sleep. Dopamine, high impact aerobics, hypoglycemia, dietary protein, estradiol. Estradiol. Extremely important in the brain, not only for all the other things that Dr. Rouzier was saying, but for stimulation centrally of growth hormone production. Arginine for suppression of somatostatin. So what you do is you change the bar so growth hormone can go up a little higher, as you'll see shortly. Secretogogues that have multiple points of stimulation. And an interesting thing that I've been seeing is patients who are on psychotropic drugs, certain psychotropic drugs like lithium carbonate, they have an incredible level of growth hormone. And some of the serotonin uptake inhibitors, Wellbutrin, can change luteinizing hormones, so you have an increase in testosterone level. So make sure when you take your histories, you keep abreast of what medications are there. And I haven't been able to find at googlescholar.com is probably the best one so far. It goes right to academic literature, googlescholar.com. Things that will inhibit growth hormone, somatostatin from the paraventricular nucleus, circulating growth hormone IGF-1 levels centrally and peripherally, dietary carbohydrates, fats, glucocorticoids, obesity, sedentary lifestyle, medication like tamoxifen also. Anything that inhibits, impedes, blocks estradiol will lead to downregulation of growth hormone production. Now you have to understand these are not absolute, and I don't talk in absolute terms. It means that all the hormones play a participating role, as was said, a symphony. So if I talk about one causing shutdown in growth hormone, it's a decrease, not shutting off totally. So it's not the extremes, it's the means. Anastrosol, which is the stuff, low estradiol and low melatonin. So you got to get good night's sleep. Okay. A side note is radiation-induced growth hormone deficiency. It turns out that those dental x-rays we get, those x-rays for a little bump on the head, if you get hit upside the head by the significant other, you don't have to run and get an x-ray. The CT scans for doing CT scans for whatever. They found that the pituitary is more resilient to ionizing radiation, while the hypothalamus, the regulatory system for the pituitary, is more sensitive. So we see in people who, even though they get focused radiation for whatever brain thing they have, it can damage the hypothalamus and they'll lose functioning. So if you do an ITT test, what will happen is you'll get a normal response to the pituitary because there's no damage to the pituitary. It's the hypothalamus. Interesting aspect for those of us who have used growth hormone, injectable growth hormone in the past, is that after the second shot, 48 hours after the second injection of growth hormone, your endogenous production of growth hormone drops by 40%, and at 30 days, it's down to 0. So all your growth hormone is coming from an injection. And the minute you stop that injection, we have cases of up to a year, because I do use Secretogogues in the office, up to a year delay in the reappearance of adequate levels of growth hormone. So this is what I tried also. Let's see if it works. So GH suppressant, there's a theory that I'll show you, which is called the threshold theory. It happens with every one of our hormones, and it's unique for each and every one of you. There's no standard deviation. There's no absolute. Everybody is so dynamically different because of the biochemistry that we have. Drinking my scotch here without the water, or the other way around, influences my levels differently. So here growth hormone goes up, and it's below that threshold, and you have no problems. The minute you get to the threshold, somatostatin is produced and suppresses your growth hormone production, and it drops out. And that might be a tenth of a second that I just showed you, and then a tenth of a second later, it'll go back up. And if you suppress it prolonged period of time by taking large quantities of growth hormone, like 3 to 5 units a day, or 2 to 3 units a day, or 1/2 to 1 unit a day, or 1/4 to 1/2 unit. I don't know what's going to do it for you. What will happen is you'll have elevated levels of somatostatin, which will continue to suppress your own production for X amount of time. And it's only through testing that you find out what for that individual X amount of time is. Also, by using injectable growth hormone, what happens is somatostatin goes up, and it's not just about suppressing growth hormone production. It's been found to inhibit prolactin, TSH, and ACTH production. So if you drive the level of somatostatin up too high, you'll have some degree, whatever that degree is for the individual, of reduction, downregulation of the other hormones. A way that you can help control the somatostatin is by using arginine, 2 to 4 grams at bedtime between that 8 o'clock at night and 4 o'clock in the morning period of time. You'll actually raise the threshold. That's a blank slide. Why it's there, I don't know. Anyway, let's now get into the actual science behind the secretagogues. That's the background. What they're finding is that there are what they're calling unnatural secretagogues. What does unnatural mean? Well, unnatural means that it may or may not have any structural homology or similarity to the growth hormone releasing hormone that our body produces. And this is a listing of that. Dr. Chrysler is one of the experts on the secretagogues, on the top 3, I think, or top 2 or 3. So if I say anything that's not absolutely correct, please be so kind as to correct me. So growth hormone releasing hormone is a 44 amino acid chain, and it's neurosecretory nerve cells and the arcuate neurons, and it goes to the anterior pituitary and stimulates the production or the release of growth hormone. And that's a little scheme of what happens. As growth hormone goes up, somatostatin increases and knocks down the growth hormone. It still occurs. Ghrelin is a stimulator growth hormone. It's secreted in and of itself from the anterior pituitary. They believe that maybe something in our nutrition, like leptin, might have an interaction with it also. And it's a growth hormone. It uses what they're calling a growth hormone secretagog receptor. They found a secretagog receptor, not only a growth hormone releasing hormone receptor, but they found a secretagog receptor that ghrelin plays a role in. And it binds to it and stimulates production. There's an article that came up, and on the bottom, there were no significant changes in luteinizing hormone, follicle stimulating hormone, or thyroid stimulating hormone. So it has a safety parameter in terms of ghrelin. I don't know, can you get ghrelin by itself? You can't? Pardon? Yeah, okay. Well, some of the products that are following are in the literature, legally, FDA, as being for laboratory research only. And I looked up what does it mean for laboratory research, because my office, my clinical practice is a clinical laboratory. So the products may not be used as drugs, agricultural, or pesticide products, food additives, or household chemicals, and that's the FDA's verbiage. So you have GHRP2 peptide, and it's a synthetic peptide which stimulates, like the growth hormone releasing hormone, the production of growth hormone. It's about $530 for 100 milligrams, and the amount that you use is variable. GHRP6 is another one, which is a 6. It's an unnatural D amino acids, because the majority of ours are L, and it has a very strong releasing capacity on growth hormone secretion using that growth hormone secretagog receptor. It's a pretty little bottle it comes in. That's the structure of it. These secretagogues are distinct, I'm reading, which I usually don't, but last part of it. These secretagogues are distinct from growth hormone releasing hormone in that they share no sequence, relationship, and derive their function through action at a completely different receptor. Hexarelin, it's been around for a long time, significantly stimulates, upregulates prolactin, ACTH, and cortisol secretion. Prolactin will suppress luteinizing hormone, thereby dropping your Leydig cell production of testosterone. Hexarelin, it's very powerful. It works very well, and you can take it in oral, intranasal, IVs, subcutaneous injections. But they found that chronic use of it downregulates the production of growth hormone. So that's homologous downregulation. Somatostatin is a 29 amino acid piece snippet off of the human growth hormone releasing hormone. Secretropin is a multifaceted secretogog and having a multi-composition to address 5 of the receptors. And that's the article on homologous downregulation. If you read it, it's open to a good dialogue about whether you believe it or not. So in youthful time, we produce an adequate amount of growth hormone between 8 o'clock and 4 o'clock in the morning. And as we get older, what happens is we lose the amplitude. We have the duration, but we lose the amplitude and the number of pulses. Let me pass this slide. Nothing here. And in looking at low-dose growth hormone stimulation using a secretogog versus high-dose stimulation, you see that in low-dose use, you get a higher amplitude of growth hormone production. But by using excessive amount, what happens is you've overshot the threshold and you've led to downregulation because of increased production of somatostatin. So you have to monitor, when we're using some of these secretagogues, you have to monitor them closely to make sure that you choose an ideal amount. For instance, if a person starts here and you give them the secretagogue of choice and they go up here and they plateau here and you want to go up and you take another blood test and it crashes just like that. It goes down, you know that you've overshot the threshold. If you have someone that you start on a dose and it goes down, it means you start off with that patient at too high of a level for their body. And all you do is reduce the dose. You cannot select a dose that is ideal for everybody first time, but you need to go back and recheck. So this is the threshold. I think you got the concept of it. So the secretogog story. A whole bunch of secretagogues. This has, the traditional standardized view, kicking out the growth hormone. And then we have all these other things, from amino acids, DHEA, dopamine, peptides, synthetic peptides, peptidines. Novo Nordisk, big company, they've discovered, discovery of new class of compounds that stimulate the release of growth hormone in a manner distinctly different from growth hormone releasing hormone, and the mechanism, they've helped to unfold it. And the compounds act both at the pituitary and hypothalamic level. So at the hypothalamic, it's growth hormone releasing hormone, and at the pituitary, directly stimulating the production from the somatotropes. So that's some of the synthetic peptides to peptidomimetics. They have no structural homology with growth hormone releasing hormone, and their dose-related effect on both the pituitary and hypothalamus. The synthetic GH secretagogue, or the secretagogue growth hormone receptor. And they possess dose-dependent and reproducible growth hormone releasing effect. Reproducible. So it's not just a one-time shot where it works. It was thought in the past that by using these secretagogues that they may lead to tachyphylaxis and stop working. Well, that's not totally the case. Another important secretagogue is DHEA. How many people give DHEA in the morning? Raise your hand. I've got poor vision, so I got to see it high hands. Okay. And how many give it at night? Good. The reason for giving it at night is that you get the added benefit of a 20% increase in the production of growth hormone at night. And I still to this day do not understand why we give it in the morning.
How about BID?
You want to give it BID? Fine. No problem. But if you want to address what we're talking about, secretagogue and growth hormone, nighttime. What is, I've been trying to find real science that attests to why we need to give it in the morning. Haven't found it. Anyway. So there's the article that talks about DHEA replacement. This was in female patients. 20% reduction in their growth hormone need for growth hormone. And it was maintained for 12 months, and there was a significant fall in serum IGF-1 2 months after withdrawal of DHEA. That's how important it is. And in the importance of DHEA and pregnenolone in treating people with testosterone is that by using testosterone, you shut off your upstream hormones, which is, from cholesterol to pregnenolone down to cortisol. You downregulate that because the feedback mechanism. And then DHEA, which is important to go to DHEAS, which helps myelination of the oligodendrocytes. You need to have DHEAS. And there's no high on DHEA. Have you had anybody with a side effect from high levels of DHEA, other than oily skin maybe, and a little acne in women? Otherwise, I keep mine at about 500. The average is about 230 in our lab. I keep it at 500. Traumatic brain injury. So only reason why I'm able to talk and hit the microphone at the same time. So the dopamine receptors play a very important role. Things like Wellbutrin will increase the production of growth hormone. Amantadine hydrochloride will increase the production of growth hormone because they work not only at the substantia nigra, but they also stimulate the receptors and help to stimulate the receptors that they upregulated. L-DOPA. The rise in plasma GH persisted for 120 minutes after the administration of the drug L-DOPA. So, L-DOPA is a secretagogue. Specific amino acids. The bodybuilders taught us a lot about taking tons and tons of amino acids. 13.5 grams of amino acids. They get a spike in their growth hormone production, and they get osmotic diarrhea to follow. It's a good exchange. Oh, what was that? Second little thing. Although parenteral administration consistently leads to increased circulating GH concentration, oral dosing that are great enough to induce significant GH release also produce discomfort and diarrhea. So here's some of the science that's been found. Arginine, 250 milligrams per kilogram per day, increases growth hormone by 60%, and that's by downregulation of somatostatin. Ornithine, 400% increase in baseline. IV ornithine, 500. So 100, is not enough to stick a needle in someone's arm unless, you want to do that. Alpha-ketoglutarate, glutamine, GABA, they never gave an absolute number of increase. They just said it did. Glycine, 6.7 grams increased growth hormone, 300 to 400%.
How many grams of alpha-ketoglutarate?
How many grams of alpha-ketoglutarate? It's not there. I think it was 2 to 3.5, someplace between 2 to 3.5. I don't remember which one. Grams. They're all in grams. Let's see, that's enough about arginine. Would use pregnenolone and progesterone to increase your GABA. Okay. Vitamin D dose-dependently stimulates growth hormone receptor, IGF-1, and binding protein 3 expression. Estradiol centrally through the estradiol alpha receptor increases the production of growth hormone through both the hypothalamus and the pituitary gland. And therefore, the use of anastrozole or any estrogen blocker downregulates your endogenous production of growth hormone. Also, estradiol is extremely important for the microglias, the immune system in the brain. Also increases endothelial nitric oxide synthetase, so your nitric oxide goes up, better blood flow. Pass that one. Testosterone. Supraphysiological testosterone concentration increases your growth hormone levels and IGF-1 and BP3 too. And it's 60 to 80 milligrams is all that's needed. And that they're calling supraphysiologic. The normal production in the male is about 4.1 to 10 or 4.1 to 15 by another article. There were 3 major articles that came out starting in 1966, 93, and 83 and 97 that male and female showed the dosing. So a 25 to 35-year-old strapping male produces between 28 and 70 milligrams a week, and a female about 15 to 20 milligrams a week.
So this is IM weekly?
Correct. Other GH influencers, melatonin, there's the percent of, or the degree of influence, melatonin, estradiol, dopamine, you can read through that. The negatives, and this one really pisses me off, alcohol really decreases growth hormone production. Good water. And obesity. And in women who are obese, who have downregulation of their growth hormone production, you can use dopamine amantadine and it'll help to bring them back up. DR2 receptors are what they're finding to be suppressed in obesity, specifically DR2 receptors. So if they're not depressed, don't give them Wellbutrin as the challenge. You can give them L-Dopa or amantadine hydrochloride. So why secretagogues don't work? Looking at the injectable products, a suboptimal dosing. You haven't figured out the dosing, and as well as too high of a dosing, which will lead to the same response of downregulation. Autoantibodies. How many people have run growth hormone antibodies or IGF-1 antibodies? It happens. It happens. So if you have people that don't have Laron syndrome, which is the receptor mosaicism, you need to check why someone who's on growth hormone doesn't have a budge up in their levels, even though you're using 2 to 3 units a day. You might find antibodies. Homologous downregulation, we talked of, somatostatin, liver issues, fatty degeneration. I've had patients who we've actually diagnosed with hepatic problems because they did not respond to anything we were doing with an appropriate increase in their binding protein 3. So you look at, and they're not on quercetin, estradiol quercetin, DHT, and testosterone can increase the production of binding protein 3. And then medication effect, both with testosterone and growth hormone, peripherally, liver, hepatic-wise, you can really influence so that these products don't work as well. You might have a high growth hormone level because it's stimulating the growth hormone, but it's not availing itself to doing what it needs to do in the liver because there's dysfunction in the liver. Oral products, poor formulation, they're not in a nanoliposomal delivery, suboptimal dosing, poor absorption, somatostatin elevation, liver functions just like the injectables. So the research literature supports the ability of atypical substances to increase the production and release of growth hormone both through a multitude of receptors found in the hypothalamus and the pituitary. These substances have been found to be amino acids, atypical peptides, dopamine, DHEA, and so forth. So delivery technology. Nanoliposomal delivery, you have a group of these products you want to deliver. Encapsulation, someone made Dr. Liu made a comment about nanoliposomal. They're cutting edge right now, how to amplify everything. So nanoliposomal encapsulation of DHEA, name it, all those secretagogues individually and groups, helps to protect the product from acid digestion. Because that's what happens to a lot of the stuff that we take in orally. We've got hydrochloric acid and it destroys it. So that's why you have to take a lot, and that's why you can give 20 milligrams of drug X to one person, they have suboptimal effects, and you give the same 20 to another person and they have excessive effect. You have someone with achlorhydria versus hyperhydric conditions, you have totally different absorption patterns. The other is the size of the nanoliposomal particles. You know, the fenestrae in the blood vessel walls are 50 nanometers or smaller. So if you have particles that are too large, you're not going to have penetrance or passive. You know, there's active and passive. Active is very ATP dependent. The passive is just goes in. So nanospheres are motions to diffuse into blood, and in this situation, like other important situations, size does matter. So a lot of the pharmaceutical companies are now looking at the use of nanoliposomal delivery because it increases the efficacy of treatment while maintaining the least amount of medication. And I'll give you a for instance. If you were to take 1,000 milligrams of your standard vitamin C by mouth, you only absorb 19%. But if you mix it in a nanoliposomal solution, you end up absorbing 97%. So it means you can either take 100, 200 milligrams in a nanoliposomal and get almost 100% absorption, or you can continue to take a powdered vitamin C, 2,000 to get that same, or 1,000 to get that same absorption. Summation, when a patient needs to raise their GH, IGF-1 levels, injectable growth hormone can be used, but at a significant financial expense with mandatory legal parameters. A number of the growth hormone secretagogues have been developed and tested and shown to provide dose-related increase in growth hormone production and release. The single approach product loses potency over time, while the multi-pathways do not. So treatment recommendations: perform all the appropriate laboratory testing, correct all the hormones and prohormones, because if you have a DHEA deficiency or a testosterone deficiency, you might get correction in the growth hormone without giving them anything specifically. So you want to do it in 2 steps. Correct everything at the baseline, and then if still need to have GH go up, or IGF-1 or binding protein 3, then address the secretogog. Select a secretogog based upon patient history of TBI. If they have traumatic brain injury, the secretogogs will probably not work. So you have to know their history, and on Sunday we'll get into that in more detail. And you monitor for 3 to 12 months and see if they respond. We have a 3-month program in the office where we use secretogog first. If they do well over that 3-month period of time, we're done. They continue on the secretogog. Every 6 months thereafter, we check them to make sure the efficacy is still maintained. And I think with that said and done, I'm done. Do we have any time?
Yes.
Okay. If there are any questions, otherwise I'll be at UCP if there are any specific questions. Just go up to the microphone or else yell out. Nighttime's best because pregnenolone becomes tetrahydropregnenolone. Allopregnenolone is a very potent anti-inflammatory and nerve stimulator. Protects the nerves. Actually stimulates the nerves, as you'll see on Sunday. There's a lot of stuff called neuroactive steroids and neurosteroids where we have manufacturing plants in every single one of our lobes of the brain. In Alzheimer's case, specifically the frontal lobe where the executive functions are impeded, what we found is that there is an absence of allopregnenolone from pregnenolone. And what it does is it protects and regenerates. Right, Doc? Absolutely. The man behind you will give us a lot.
What doses of methodologies and Wellbutrin do you use?
I don't use Wellbutrin because that's in Dr. Cass's venue, maybe. Is it? No. Amantadine comes in 100 milligrams. And what you do is you start with 100 milligrams. At nighttime. At nighttime. Side effects of amantadine, increased libido, dry mouth, insomnia, if they're really reactive to the dopaminergic response. So you tell them if they do have it, take it earlier.
And how high do you go in a man?
Depends on you and your testing of their levels of growth hormone. There's no fixed number. It's all based upon you performing the services that people come to you to perform. Okay? Clomiphene is a luteinizing hormone congener. Stimulates right to the testes. I haven't seen any articles on it. I use clomiphene. Yeah. It works on a different pathway. Yes? No. Just go to UCP. We'll talk. That's off CME. Okay. Yes, sir. S. S is the one that centrally stimulates the oligodendrocytes to produce more myelin. Okay? Yeah. I keep mine between 450 and 500. I can't hear you. You never needed a microphone to talk to me before.
Well, because the proximity is a little bit different.
Okay.
So a question, so what you're basically doing is if you cannot stimulate the pituitary or the hypothalamus in terms of inducing GH expression, then you will actually go to the more of the traditional endogenous
Correct.
approach.
Only after doing a challenge test.
Okay. One question on this. What percentage of your patients over 60 will respond to using the various things you've spoken about today? Is it 50%?
When the next article comes out, hopefully you'll have your answer.
Okay.
I can't tell you right now.
Okay, because the literature seems to indicate that most people will not respond.
Correct, not true. My oldest is 94,
Okay.
responding.
Maybe because you have such powers to induce it, but because most people have problems to get these cells to secrete what they're supposed to secrete.
Back to square one, as long as all the other hormones are brought up to optimal levels, you'll get response. Okay. It's not based upon just doing one thing. It's about correcting the estrogen, testosterone, the progesterone, the da-da-da, and so forth. If you just, take everything out of isolation and only address one of the hormones, you're going to fail.
Okay, why in the literature does it say that estrogen has an inhibitory effect on the release of GH?
Peripherally, it does. Growth hormone like prolactin has a dual receptor, and they found that peripherally that it inhibits the growth hormone to growth hormone receptor, which is the same as prolactin receptor. So it does peripherally inhibit that, but centrally through the alpha-2 increases growth hormone production. So you have it there. You just have to make sure you don't have too much estradiol in the periphery to create the problem with the receptor.
Okay, thank you.
Okay. Any other question? Okay. Thank you.